Well, the success rate is around 60, 70%. But I can tell you in terms of impact on quality of life and how people feel about it, they're very, very happy and very grateful. And they'll let you know that.
Talk a bit about the fulguration work that you've been doing. So the last time we chatted on an interview, you went into a lot of detail about how fulguration works, how you diagnose someone with recurrent UTI that might be appropriate for fulguration. And so people can go back and watch those original videos. But I wanted to talk about the study that you published more recently, which is about the very long-term outcomes of fulguration. So can you tell us a bit about that? What was the follow-up time frame for this study?
I have the paper in front of me, but so I can tell you the median follow-up was 11 years. And
Quite a long
71 out
time.
of 90, 71 out of 96 women were beyond 10 years.
Okay.
Yeah.
That's quite a
But I
long
would like to, I would
follow-up.
like to something important that you may not have realized is, and that's something new for me as well. When I started to look at my outcome, I realized that I had apples and oranges in my patients. I had
Hmm.
women with very localized areas of infection, so we call the trigone, and the base of the bladder.
Hmm.
And I had women with very, very diffuse
Yeah.
disease. So the degree of extension of the infection in the bladder turns out to be a critical factor for predicting the long-term results. And
Okay.
as any disease, if you tackle it at an early stage, your chance to do good are better than when you have a much larger volume of disease to take care of. So this report is specifically about what I started to describe as stages 1 and 2. I came up
Hmm.
with a classification just for myself to be simple.
Yeah.
The landmark on the bladder, we don't have that many. So I took the trigone, which is a triangular area between the ureteric orifices and the bladder neck.
Hmm.
We call trigonitis. That's what we call it stage 1. When we see lesion extending to the base of the bladder, just beyond that area, we call that a stage 2.
Hmm.
When they go lateral to the ureteric orifices, we say it's a 3, and when the whole bladder is involved, it's a 4. So
Okay.
nothing too complicated. Anybody can relate to that.
Hmm.
And then after that, there are other things that makes it more complex, which is the density of the lesion. Are they really close to each other, or are they separate? Are there more good areas of the bladder or bad? We try to work with AI to try to figure this out. We have
Okay.
pictures. There are other things we're trying to understand to stage the disease better. But right now, this report is only for the early stage. And the reason
Okay.
I did that, because I think that's a group that stands the best chance to do well long term, obviously, because you start with a smaller volume of disease. Why do some women have their bladder involved? Were they a stage 1 before they became a 4? Were they a 4 from the get-go? That I don't know. But we
Hmm.
studied the bacteria before and after. We studied the bacteria in those two groups of women to sort out. It's really difficult because the data that we have is based on the routine culture. We don't have any sequencing
Yeah.
data to really characterize those bacteria very precisely. So again, more that we don't know than we know, unfortunately. But try to be more scientific and systematic about what we're reporting. So we've reported on stage 4s. We've
Okay.
reported on the simple classification, but that's reported specifically for the early stage.
And how did you measure success amongst those patients?
Well, we only had one option for that, which is the definition of recurrent UTI, which is,
Hmm.
3 in a year. So we took cure, none, improve, 1 or 2, and failure, 3 or more.
Was that
But it
specifically
really can, figure that out. It's not complicated. It's just based on
was it
design.
compared to how many they experienced prior to the fulguration though, or just a general definition?
No, that's the general definition. So here you're hitting a very crucial point, and that's very hard. And I'd
Mm.
say whenever you send a patient, please have them collect the urine culture data before we see them, because most of the time it's, very weak data. Some
Hmm.
people say, yeah, I've had infection for the last 10 years, and you search the cultures and you can't find anything.
Yeah.
Other you find a plethora of culture that you say, oh my God, that's a great day. But for many of them, they may have had symptoms, they may have had treatment, they may have gone to an urgent care or called a doctor for an antibiotic, but that doesn't mean that you know what's growing in the urine. So the culture documentation is very weak part of our data set. We have a large data set with RedCap. I don't know if you're familiar with that, but that's a very good way to capture data. And I can tell you, we always struggle with what happened before.
Yeah.
So, if you ask me what's the reduction, well, it's obvious. People tell you, it's wonderful. Doctors have not had an infection in years now, and I used to have them all the time. So having it all the time means what? For some people, it could be, 5 a year. From others, it could be 5 in 2 years. It's just that that's a notion it was recurring is coming back, but the severity of that recurrence and the documentation of that recurrence before we intervene varies a lot. So maybe a good message to your public is to, capture this data because it's useful for us to know what are the strains growing, what are the resistance pattern, how many you've had. And some people are doing great and come with very well written documents with everything. With some others, we just have a hard time figuring out,
Yeah, it's
Answer
complicated
your
for
question, how
patients.
severe was the disease before we saw it.
Yeah, and it's complicated for patients too because they often find that going to get a culture doesn't result in treatment that helps them. So they tend to stop going if they're not getting helped.
That's true, but also some places don't send the culture.
They don't, it's
They
true.
just
So
check the urine analysis, the symptom they treat, and they don't send the culture. And sometimes people say, "But I don't know if I had the culture done." And then
we
I
see
just
that
had
as
that
well.
yesterday. We went through the whole phone because people now have access to the phone and their story. And there was many treatments, but only a few urine analysis and only one culture, which happened to be negative.
Yeah.
So, that's
The approach to care is very inconsistent, and we find that globally. So it's quite complicated to get patients who have a very well documented history if they're entering a study.
very difficult, very difficult. But I think it's because if we told the patient what is helpful to us, I think they can do a better job. We've never spoke up and say, you can help us by bringing a good history, Same when someone comes, has a complication after a surgery, it's ideal to get an operative note. Otherwise, it's a challenge to know exactly what was done, what happened during the surgery. It's the same, analogy. And a lot of people don't know. I had some bladder suspension. I had some prolapse repair. Maybe I had mesh. I don't know if I had mesh. It's the same problem that we have is we have good historians and we have some less informed people. And so the trajectory I'm offering in this paper is from the moment we did the fulguration forward, but comparing with before is difficult. We've done a cost study, which I don't know if I sent to you to look at, but we look at 1 year before and 1 year after to see the impact of fulguration. And it clearly obviously improves the cost because you don't need to be getting cultures and antibiotics all the time. And so the impact of the fulguration was very noticeable. But this is only 1 year before compared to 1 year after.
Right.
That's the timeline that we had.
For those in that cured group, would they then not need antibiotics after a certain point after fulguration, or do they still sometimes get UTIs?
Well, in that group, no, if they were cured, they were cured. Now, we don't have 20 or 30 years. So, obviously the body changes. Some may have gone through menopause and then since maybe some have developed, diabetes or other risk factors, breast cancer. So, we're not saying that this is a guarantee, nor are we saying that everybody will be well. The success rate is around 60, 70%. But I can tell you in terms of impact on quality of life and how people feel about it, they're very, very happy and very grateful. And they let you know that. They send you letters, they send comments. It's been the turning point for many of them. And even when they have infection, I would say, Melissa, that it's easier to treat. The strains are usually much more sensitive. We've definitely changed their microbiome and their internal world. And we will know more with the upcoming NIH study that we're doing on fulguration. We will be able to see that more scientifically, just exactly what has changed from before and after.
That's great. And you mentioned that it's more effective if it's earlier or it's more restricted to a certain area of the bladder. Do you think that means that that fulguration should be considered earlier in the recurrent UTI journey? Because most people that consider fulguration, they're much further along. They've had many infections, possibly for years, and multiple rounds of antibiotic treatment.
You have to give me 5 years to answer that question because I need to know from that randomized trial if fulguration is proven through centers and with science to be what my experience has been so far. So if that study showed that fulguration is a way to go, I would say yes to your question, and I hope it will show that, but I don't know that. So I'm not going to say something that I don't know. I think intellectually it makes sense. What I would suggest, more practically speaking, encourage people to have a cystoscopy in the office to determine whether they have chronic sites of infection or not, because that's the missing link. And the missing link comes from the fact that cystoscopy is not currently in the guidelines to evaluate women with bladder infection. And it's not because people used to do cystoscopy to detect bladder tumors, which are exceedingly rare, unfortunately, and not to stage how bad the infection is or whether they have any chronic areas of infection. Some women don't. Some women don't. We've published that. We've looked at the role of flexible cystoscopy in women with recurrent UTIs. Some bladders are completely normal.
We hear that too.
If you don't have that level of information, you just don't know. So right now, when I have that situation, I will treat people according to guidelines, which is currently 6 to 12 months of prolonged antibiotic therapy. I know that there are countries in the world that's not allowed, the UK, but in the US, we're allowed to do that. And then we rescope them. I oftentimes don't wait 6 months. Sometimes I wait more like 3 or 4 months to see if they can really detect a change. And then we decide at that point, do we continue with antibiotics if we see an improvement, or do we switch to fulguration? So I am on the lookout for fulguration if that's going to help people early on, but they still have to follow the current guidelines because fulguration is not a guideline-approved treatment yet.
To attempt fulguration, do you need to be able to see areas of chronic infection on cystoscopy?
For me, yes, because I don't know why I would do that otherwise. This came from biopsy-proven bacteria in the tissue of these women. So my thought, and maybe I will be proven wrong one day, but I think most people understand that that's what happens in the animal models. So it's in human, it looks to be the same. It took the work from Dr. Denisco and special immunofluorescent stains with a special preparation that she basically described to prove that there were bacteria in this tissue that were fulgurating. So currently we are biopsying people ahead of time to know what happened in the tissue, the amount of immune reaction, immune cells, extent of infection, extent of inflammation, where are the bacteria, how deep they are. All this we're studying right now. There'll be some interesting data coming up. I don't want to say too much, but we're working in that field very well to understand better what's in the tissues to start with. And I think if they are deep-seated and the antibiotics cannot get there, the fulguration superficially helps basically open them up. They cannot hide anymore. And then A, the antibiotics can work, B, they're not buried in the tissue where you can't get hold of them. And so you break the cycle of reinfection when you do that. So I think intellectually, from the knowledge we have, fulguration does make sense until we will come up maybe with biofilm disruptors and ways to do things without cauterization, which would be ideal, like placing a solution in water that takes care of the problem. I'm all for that.
Yeah, me too. When you take the biopsies of the areas of chronic infection, do you take biopsies of seemingly healthy tissue so that you can see different microbiomes or organisms in those places?
I did initially, and then the RIB rules changed at my institution. I'm no longer allowed to do that.
And when you did do that, did you see that there were differences?
Yeah, there was. I'm so happy to have that chance to do that because we did find that there were bacteria on the area that appeared visibly normal, and we reported that. So even when I do a scope and it looks normal, I know that they're hiding. So one of the grants we have right now with a brilliant chemist at UT Dallas is to use a special dye to try to identify what these bacteria are. And that's another fascinating grant that's advancing very quickly. So the dye works in the cell line, it works in animal tissues. We're just waiting for the proof that it works in those human biopsies. So we're waiting for the RB to give us permission to take a biopsy to prove that dye can identify where the bacteria are.
That would be interesting to see.
That would be another turning point for us. Then we could get to those bacteria with other form of treatment than just fulguration.
Yeah, it sounds like there's still many things that you're hoping to discover, but you have been using fulguration for quite a long time now. And over those years, have you changed your approach to fulguration or the protocols that you use after fulguration?
Always the same, simple, one little scope, little tiny bug bee. heard people asking me about other ways of fulgurating with the resectoscope loops or laser. I don't know any science behind that, but I'm concerned with things that can penetrate deeper in the tissues. I want to stay just on the surface. So as you've seen in the movie, we're just dealing with that surface layer. The resectoscope loops are used to resect tumors, to resect prostate. They go deeper in tissues. I think they can damage the bladder wall. I'm not offering that to my patient. I don't think that's a good thing to do. Maybe some people do and have good results. I'm not, disputing that, but it's not something I want to even take a chance of. I don't want to damage the deeper part of the bladder wall. And laser is the same problem. It's harder to judge the depths of penetration.
Right.
It's more costly, not available everywhere. So the scope with all cauterization is a very simple thing that any urologist has done for bladder tumor or other lesions in the bladder, ulcers, something like that. So it's very readily available. It doesn't require any sophisticated, tools.
Okay.
So I've no. It's always the same technique. I think it's changed there. Sorry.
No, it's fine. I mean, it's good to know that you've been using this
Simple.
consistent approach. Yeah. But
Simple
what
and
about after fulguration? Do patients usually have to take oral antibiotics for a certain amount of time?
they don't have to. We recommend for the first 6 weeks a daily prevention.
Okay.
We recognize that the tissue is more bare, it's more, and that we have exposed bacteria. So if you have a bad infection and when you start to heal your bladder, it's obviously not great. It's going to create another cycle of inflammation. So we recommend this 6 weeks daily prophylaxis with whichever they can tolerate. And then some people wish to continue. Some are actually happy to stop, and we monitor them with symptoms and culture if needed. It's a recommendation. It's not, mandatory. If people have had a long list of allergies and resistance and we have no antibiotics to use, then we use nothing. That's okay. But it makes sense to at least just after the fulguration to protect them from another infection soon after.
Okay, and what can someone expect in terms of pain after fulguration, and how would you manage that pain?
So we are gathering the data on that. Two of my medical students are looking back at our history of how people did after fulguration. So I don't have the final overview of that.
Okay.
From my overall personal impression, which may turn out to be wrong, but that's why we have to look at data before we have our impression. I cannot predict very well who will and will not have pain. And I think I mentioned that before, the depths of penetration of these infections, the sensory nerves, where they are, how people send signals to the brain in terms of pain, that's also a very complicated story. So I tell my patient to expect some discomfort for a few days, like when you burn yourself on the skin. There are things to probably avoid. Nobody should do horse riding or, drive, hours and hours in the car and have their bladder go up and down like crazy, or have intercourse, intensely for a while just because it's just below the bladder. So you have to let the tissue heal. It's a burn. If you burn your hand, you don't want to touch it 25 times a day to hurt more, correct?
Yeah.
Or put it in water or do something with it. So it's saying you have to protect your bladder a little bit. The urinary environment is very acid and very toxic. So, you know that it can create burning. And I don't know that there's any really way to predict who will. And if they have pain, what I know is pain pills don't work.
Okay.
They don't work. They work on joint, they work on muscles, but you can take any pain medication you want, including, strong pain medication, codeine, morphine, that puts your body to sleep, but it won't do anything for your pain.
Interesting.
So what we use the most are things that people can take over the counter, like ACO or Pyridium, or the different limited, analgesics they can help. Maybe anti-inflammatory agents work for those who can tolerate, Motrin or. But that's very poorly studied.
Okay.
We really don't know because we don't have to measure that other by the symptoms, and the symptoms come and go. One thing, though, I need to mention that's important is if your bladder hurts, please don't drink 5 gallons of water. Just limit your fluid to rest your bladder. Because, your bladder doesn't have to be stretched 20 times a day. Because some people go home and drink thinking, I'm going to flare up all this infection.
Yeah.
So, and they call the next day, they've been up all night and they're miserable and have bladder cramps everywhere. So that's a no-no.
Okay.
Please don't do that. Okay.
Makes sense.
Make sure your bowels move because, if you get constipation, that also can affect your bladder function. And after that, it's just even those who have pain or discomfort, because people really use the term pain, they use discomfort or pressure or discomfort when they urinate. They realize that it's going away. They call you the first week, but the second week they're already better, and by 4 weeks it's all gone. So you're not going to live with that forever. It's not a permanent handicap. It should clear out.
Okay.
Unless you really have done something wrong technically, or you've been much deeper than you should have been. But if you're just at the surface, it's the healing process should be good. So we use the same cautery, the same low voltage on the cautery, so we don't use high levels that can create more burn and more damage to the tissue. So I think you have to be gentle and careful of how you do it.
Okay. Yeah, it's good to reiterate that because I think we covered that in our first interview too. So people can go watch those videos for more information about fulguration itself and what it looks like afterwards. Earlier in this interview, you mentioned bladder removal, and we did get a question from the community about that as well. Like, at what point would bladder removal be considered an option? And is that something that is done very often for recurrent and chronic UTI patients?
No, it's done rarely, fortunately. I think the answer to the question is when your life is on the line. If you're at the point where you have no more oral antibiotics to treat your infection, you have been hospitalized several times, you have been septic, and you have to choose between losing your life or losing your bladder, I think, you should do so. So you can imagine this is not frequent, but it does happen in the specialty practice like we have. So we've published our experience with that.
Okay.
The blessing nowadays is that the bladder removal can be done robotically, at least in the US. And so the operative challenges that we used to have with open surgery are way less. The pain is much less, but you still have to live with the bag for the rest of your life, like someone who had a bladder cancer.
Yeah.
But it's a better life. I mean, you talk to people after this. I just got a letter from someone who had that 3 years ago, and she said, I really wanted to let you know that this decision has changed my life for the better. So not to say that's true for everybody, but it does. When you think, I can't do anything. I have only 1 or 2 IV drugs left. I have a super resistant strain. My bladder has not responded to multiple rounds of fulguration, which is oftentimes what we're trying to do here. We fight to keep patients' bladder, Melissa. We do fight. But there are times where I say, time out. You're going to get sick. You've been sick. We don't have the luxury of taking that risk. I have people coming with Mediport. They've had countless PICC lines. Our infectious disease people have struggled to keep them alive. So I think, there's a time where you have to make that call. But fortunately, it's rare. It's a very last resort. Oftentimes, that was called stage 4. Those are women with very bad infection to start with. They have big double bladder, very resistant type of strains. You look at their resistance pattern and you see everywhere. There's maybe 1 or 2 as sensitive for an IV drug like ertapenem or meropenem or amikacin. So you're realizing that you're narrowing down on the options you have to take care of them.
In those types of situations where the resistance is quite high, do you still recommend fulguration first before moving on to something like bladder removal?
No, I give them the choice, but I can tell you, and you probably would relate to that, people want to keep their bladders.
Yeah.
So if there's any hope that we can do that and they can get better, and a lot of them will. So I think it's worth fighting for that. But it's usually, on average, I would say it's probably 2 fulguration, 1 to really get rid of the majority of the infection. And then when you come back 6 months later, whatever is left, you go back after. And we even had them 3rd and 4th fulguration, and we've published all that. So yeah, I will not give up. But there's time I will say, I think, it's not working. You have, and that can just be their comorbidities, maybe their age, their diabetes, they are on immunosuppression drugs because of transplant, whatever that makes that fight between the host and the bacteria leaning more to the bacteria winning, and we just can't change the host.
Yeah, I think it's good for patients to understand the escalation of treatment options too, which is why we do these interviews so that we can ask questions about that. So it's helpful
Right.
to have that insight shared.
And I think, people always ask me what's my thought process. So in the paper, I think I've sent you entitled Gaps in Knowledge in our UTI, I tried
Hmm.
to look at all the gaps in knowledge for the things we don't know. But there's one particular table I made. I was asked to do that to kind of show my progression from the time to present, the scope findings, the decision we
Hmm.
made, the fulguration result. So that's kind of the flow that we're following right now.
Okay.
And I've not changed that. It's been kind of my way of thinking and processing over the years. Obviously, every day is different severity of UTIs, and that's something we're trying to put also into a quantify that better.
Hmm.
We work with infectious disease. We work with our partners in GYN and colorectal to try to improve everything we can about their bowel hygiene and GYN sphere. So it's a multi-pronged approach.
Yeah, I think that's probably a helpful paper for us to include in the video description along with the others that we've discussed in this interview. But since we
Yeah,
chatted the last time,
it's humbling because it shows you all the things we don't know, but at least it summarizes a
and
little bit that
it's
we know. So
sometimes a bit frustrating and depressing to read a paper like that because there are so many gaps in the knowledge, but that is why you're doing the work that you do, as are all the other researchers that we talk to for this channel. And
yeah,
it's encouraging to see the work being done, even if we don't have all the answers yet.
thank you. Yeah, we do. So as you mentioned, we've been blessed with a center.
Hmm.
That was a gift from the Kin Foundation to me to be able to help as many women as I could and train the new generation of people in the field and fellows. So that center has international number, local numbers, emails. So we're happy to help people within the limitation of time
Hmm.
and resources. But we have a lot of ongoing solid clinical trials, a lot of submission to the NIH for different level of grants. We call R1, which are 5-year grants, or R21, which are more short grants of 2 years. We love donation to help us with our research. It's huge when people can do that because
Hmm.
we can then move on to fund a primary data project. And we have labs with brilliant young people doing their PhD program that just need that type of support to get moving. So
Yeah, it's really
I know you've
important.
been very supportive, and I've been immensely grateful to you for all the work you've done in your own area. But that, so kudos to you. Thank you.
Oh, thanks. We'll also have to get an updated list of any trials you have running so that people based in Texas can reach out to us for that information. And I'll put a link to the new center in the video description so people can find you more easily.
Absolutely. We have website and newsletters, and happy to help. That's what we're trying to do.
Well, this has been very insightful again, and our community really appreciates the work that you and your team are doing in this space. So I wanted to thank you for sharing your
I
time with
hope I have
me.
some interest for you before another 3 years. So let's hope that maybe a
Yeah,
year or two.
I think it'll be faster this time.
Yes, I mean, a lot of people are motivated, and we have built a good group of people. And I think the NIH should to recognize that we have a strong center with
Hmm.
many facets and different level of expertise from metabolomics to microbiology, etc. So I hope they will continue to help us, move this project along, both on the scientific side and the clinical side. So,
Yeah, that would be great
but
to
but
see.
it's partnering with people like you that makes it fun too. So thank you.
You're welcome. Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.